we'll start jumping in. I'll get started by welcoming you to the third season, the third year of Osteobites. Like, who knew we'd still be here? Like post-COVID, when this was kind of like a COVID thing. Anyway, thank you for being here. My name is Anne Graham. I'm an OsteoWarrior and Executive Director of MIB Agents. Today, we are all very excited to talk with Dr. Pete Anderson of Cleveland Clinic. We have so many questions that have come in for Dr. Pete. Before we do an introduction of the doctor who needs no introduction, everybody knows Dr. Pete Anderson. Dr. Pete, as he is affectionately known, is an MD PhD of Cleveland Clinic Children's Hospital. He is a clinician researcher in the Department of Hematology Oncology and blood and marrow transplantation. He has practiced at the University of Texas, MD Anderson Cancer Center, where he was section chief of non-neural solid tumors. And he was at Mayo Clinic, where he launched the pediatric bone marrow transplant program. He received his medical degree from Mount Sinai School of Medicine and had his residency in both internal medicine and pediatrics at Duke. He had a fellowship in pediatric hematology oncology at University of Minnesota. And most importantly, to me anyway, he is a member of MIB Agents Board of Directors and our Scientific Advisory Board. Before we get started with the many questions that have rolled in for Dr. Pete, I want to tell you a little bit about MIB Agents. We make it better for families, kids with osteosarcoma in 3 ways. We do this through education, support programs, and research. Education programs include our annual MIB Factor Conference, our testing and research directory, Osteobites, which you all know about apparently, clinical trials. We have a 60-second search on our website, and the book, Osteosarcoma From Our Families to Yours, which is available for free download on our website. Actually, everything we do is free for osteosarcoma families, or you can request the actual book. It's available in Chinese, English, and Spanish. We also have support programs, which includes a verified osteosarcoma resource packet with our book. Lots of good resources there. We have gamer agents. We have warrior mail. If you want to write or you want to receive mail, let us know on our website. Ambassador agents who are trained to support their fellow osteo warriors, prayer agents, whatever your spiritual practice, end of life missions, bereaved parent support programs, and young adult survivor support group. Finally, research. Outsmarting Osteosarcoma funds annually osteosarcoma specific research. We support researchers and we share the research that we fund and that is funded otherwise. If it has to do with osteosarcoma, you're going to find out about it with MIB Agents. So much of this is possible because of MIB Agents family funds. They really help us support our programs, support our research, certainly, and our education components as well. If you need more information about any of this, just let us know. If we can help in any way, let us know. Just go to mibagents.org. Dr. Pete, would you start the introductions, please?
Thank you very much. We've got Mia, Kara, Andrew, Christina, all involved in the organization, and it's a pleasure to be able to share and also show how much MIB cares for osteosarcoma patients and their families.
I'm Mia. I am the Vice President of the Junior Advisory Board for 2022. I am an osteo warrior and I live at home in Los Angeles with my mom and our 3 cats and soon to be 2 dogs. So.
Hi, my name's Kara. I'm from New York. I was diagnosed with osteosarcoma in 2022. I'm a left above the knee amputee and also the MIB Junior Advisory Board President of 2022.
Hi, my name's Andrew. I'm from Northwest Indiana. I'm a junior in high school. I was diagnosed 4 years ago and declared NED about 3 years ago, and a member of the Junior Advisory Board.
And I'm Christina Iptoma. I'm mom to Osteo Angel Dylan, and I'm the Director of Scientific Programs for MIB agents, and I am in the San Francisco Bay Area.
Okay, so jumping right into questions regarding managing side effects and toxicities from chemo, what are the most common side effects from MAP, i.e., tips to manage clearing high-dose methotrexate, keeping lab counts up, mouth sores, nausea, all of that not fun stuff?
Wow. When I'll have to admit, I don't like prescribing chemotherapy, but it works. So what you try to do is anticipate the common side effects and make each cycle better. So the very first one is doxorubicin cisplatin. And unfortunately, cisplatin is probably one of our most metagenic agents. So nausea is very common. You can't use every antiemetic right off the bat, but there's different causes of nausea from chemotherapy. There's the immediate nausea, and that's what we use Zofran for, and that class of drugs. There's delayed nausea from cisplatin, which is worse a day or two after chemo, and emen or fosaprepitant work against that. There's also an effect of using dexamethasone or Decadron, which reduces inflammation, which has good anti-nausea effect. And then there's a fourth drug at bedtime, olanzapine, which helps your mood, but it's been found out to help nausea too. So usually I'll start with 3 drugs as an antiemetic regimen. The longest lasting one is palonosetron, also known as Aloxi. It's IV, has fewer drug interactions than Zofran. And since the cisplatin dose for MAP is so big, you should plan on having nausea unless you really work hard to get rid of it. So I'll use those 3 drugs. Other things about the nausea is, this might seem obvious after you've seen it a few times. Don't be in a rush to start chemotherapy. So you put in the port, sometimes you're nauseous from the anesthesia. Just start the next morning. It's not going to make a difference, but you'll have less anticipatory nausea in the future if you have a good experience with the first cycle. And then last but not least is everybody asks about marijuana, and but oncologists have the ability to prescribe THC in a pill. So it's called Marinol, and that also has a good side effect. It increases your appetite too. So if somebody doesn't respond to standard antiemetics, I'll often add Marinol. If they're struggling with appetite, we may use another drug called Megase with their meals. So I'd say the most common chemotherapy toxicity is on the GI tract, and that really requires, I call it therapeutic alliance. So you're trying with the family and patient to learn what went well and what could be improved, and then improve the next cycle. In terms of delayed chemotherapy side effects from the doxorubicin cisplatin, the doxorubicin will make the blood counts low. And usually the nadir is 7 to 10 days. So with the first cycle, you're trying to not only give education, but you've had so much information. What do you do when your blood counts are low and you might have a fever? So I like the mental dress rehearsal, or sometimes I'll actually have the family put the number that they would call if they have a fever. And the chances are at least 2 out of 3 will be after 4 p.m. before 8 a.m. or on a weekend. That's just how many hours there are in a day. And do they come through the ER? Are they a direct admit? Do they come to clinic? But they have to call somebody for advice. Another delayed side effect is the effect on the lining of the GI tract. So the most common and obvious is mouth sores. The best defense against this is to never stop eating because it helps. Glutamine is the fuel for the lining of the mouth, the esophagus, the intestine. And if you don't have enough protein in your diet to provide glutamine, you tend to get more mouth sores. This is true whether it's doxorubicin or the high-dose methotrexate. So usually I'll say something to the effect, it may be difficult to maintain your weight, but if you do, you'll have fewer side effects. And 5% weight loss, I get concerned. 10%, you end up with each cycle being more and more difficult. So you may need extra supplements or even an NG or a G tube. So let's not have that conversation. Let's maintain your weight. The other thing for mouth sores, full disclosure, is a swish and swallow mouthwash with glutamine, but also a sugar, so you get more glutamine into the lining. That's called Helios. I invented it. I have the patent, but I don't make any money because the business model's poor. We give it out for free if you're under 18, and you get it from enlivity.com. And then last but not least, in terms of common side effects, are infections. So you're trying to prevent infections. And although everybody's worried about catching infections from somebody else, the most common problems come from your own body. So it's the bacteria in your mouth and your intestines. And the best defense against serious infections like E. coli from your intestine getting into your bloodstream is to have good enteral nutrition. So things like maintaining adequate calories and protein, but also having good bacteria in your diet, like yogurt or kefir. If you're constipated, kefir actually helps a little bit too. So if you're on pain medicines, either post-op or because the tumor hurts, kefir is another thing you can do to manage it. For other regimens other than MAP, the ifosfamide tends to cause less nausea, but it can be given two different ways. It can be given over 5 days or continuous infusion over 2 weeks. If you give it over 2 weeks, you have way less nausea, less problems with low platelets, less problems with the kidney. So you can give more cycles, but it's also outpatient. So those are, in a nutshell, common side effects and some of the management tips.
And then going off of that, what would you say the side effects are of TKIs?
Oh yeah, you'd like to think oral drugs are non-toxic, but the tyrosine kinase inhibitors, the TKIs, do several things. First of all, the most common toxicity is GI upset, sometimes diarrhea. And the ways to handle that probably is to make sure the lining of the GI tract is healthy, so it's good enteral nutrition. You may use Helios for that too. The other way to help the GI toxicity is time of day. If it's tolerable, you might take it at bedtime. And the same thing goes for fatigue from this class of drugs. It's okay to be fatigued while you're asleep. So you might consider time of day that you take the pills would affect the toxicity. The longer you take these drugs, the more common we see effect on the thyroid. For some reason, the thyroid gland just can't make enough thyroid hormone. So your doctor will be checking your thyroid function. It becomes low, you just take a thyroid pill replacement. But the fatigue might not be from the drug, it might be from low thyroid. And then last but not least is slow wound healing. So we can't start these drugs right after surgery or the wound won't heal because it inhibits vascular endothelial growth factor, which is how your body makes new blood vessels to heal wounds. So you generally have to wait 4 to 5 weeks before starting them.
Next we had a question. Is it beneficial to use cold/frozen gloves and socks during chemo infusions to minimize the risk?
That's a good question. Generally for cisplatin, doxorubicin, high-dose methotrexate, we don't see enough of the palmar and plantar rash to do it in everybody. But if you have one cycle where you have that, cold packs is very reasonable to do. On the other hand, there are some drugs that cause this a lot, like doxorubicin and liposomes. That's one of its more common side effects. So during the infusion, we'll definitely have cold packs, and anywhere you sweat is the hands and feet rash. Regorafenib tends to cause this too. So one of the TKIs. So what you're trying to do is minimize heat and sun exposure while you're on regorafenib.
Are there any supplements that can help patients get through chemo and TKIs?
That's a great question. I wish there were some straightaway go-tos other than the glutamine, the Helios. Probably the ones that you buy on the web or in the grocery store. If they worked real well, I would have heard of them over and over again. Probably the one that comes up the most is, should you be on probiotics? And every time we ask the ID people about it, they're against it. Not that we don't see positive blood cultures for lactobacillus and things in probiotics, but they really don't know whether you should or shouldn't. The way I see it, they can't argue against natural foods like yogurt or kefir, so I would do that. Other things we see people commonly taking, I think for me, a good rule of thumb is I have both parents take them for 2 weeks, but not the patient. So if they really like it, they feel great on it, go for it. But if they're just wasting money, then they could save a lot of money by not doing the supplements. Also, sources of information on drug interactions would be the oncology pharmacist that works with the clinic, and food supplements, the dietitian. So often I'll ask them to get involved. And it kind of takes the focus off some important things. You're going through enough, yet you're trying to take all these extra things. So it's a good question. Should you be doing that or concentrating on what's important?
As far too many of us know, osteosarcoma tends to metastasize to the lungs as well. So pivoting to that section of questions, when do you think surgery should be performed? For example, if nodules in the lungs are calcified but inactive, should surgery still be performed?
That's a great question. All metastases are not the same. And you want to make these decisions based on data, not feelings. All of us want the mets gone. Sometimes they're not. Sometimes they're just calcified scars that can sit there, particularly if they're really tiny, like 1 to 2 millimeters, and not changing. On the other hand, anything a centimeter or bigger tends to be a metastasis. It may well have viable tumor cells in. So the question of timing of surgery is a good one. Often I think it's best to do, if you're responding to therapy, what I call a plateau of response. So you're taking out as many nodules that are as dead as possible. On the other hand, if you have 2 or 3 scans in a row and there's gradual growth, you can see the pattern. They're going to have to come out. And it's really at a time, I'll counsel families, time good for them and good for the surgery. It shouldn't be an add-on rush case. It should be very thoughtful surgery. And you want to do the surgery in a way that the surgeon does as complete of a job as possible. If there's just 1 or 2 nodules on the edge of the lung, it may be easier to do than if there's a whole bunch where you have to get a good response to chemotherapy and then an open thoracotomy. So each is different in location and time specific.
Great. And speaking of thoracotomies, what are the general surgery options and differences? For example, a sternotomy versus a thoracotomy versus cryoablation.
If you're removing a nodule surgically, there's probably 3 standard approaches. There's the median sternotomy where you get exposure to both lungs. That we tend to do less in sarcomas because it's hard to get the posterior, inferior back parts, and that seems to be where many metastases are. It's kind of like the lung's a filter and some occur there. So it's hard for the surgeon to get to that part of the lung from a median sternotomy. On the other hand, if it's right next to the heart or the bronchus or something like that, then the median sternotomy might be an approach. We use the video assisted thoracoscopic surgeries if there's limited amount of disease and it's right on the edge of the lung. What happens there is the surgery's done using image guidance, and then they have to staple a wedge and then remove it in a plastic bag without leaving any behind. So if there's concern you're going to spread tumor between the chest wall and the lung, they tend not to do the video assisted thoracotomies. On the other hand, if an experienced surgeon, relatively easy to get, it can be a lot less painful and you get out of the hospital faster with the video assisted surgery. So sometimes it means doing a tumor board or getting a second opinion to make sure you feel comfortable with the surgery. I like to tell the families, I think what the surgeon does is more important than chemotherapy too, because then it's just local control. We wouldn't like treat a leg or an arm tumor with chemo alone. So you have to get surgery if it's big or it's growing.
Great, thank you. And what about cryoablation versus surgery?
Oh, that's a great question.
What
It's
is your opinion on it?
very location specific. You can think of it as, although you can put a probe in a tumor and it's extremely cold, it's like minus 70 degrees Celsius, and kill a nodule completely, watch the ice ball form under CT guidance. Some areas you can't because you can't get them cold enough. Let's say it's next to a blood vessel. Also, you don't want to freeze normal structures that are real important either, like nerves. So it's very location specific. Probably the area I've seen cryoablation work best is for bone metastases and really hard to do surgery areas like the sacrum. It's probably less useful for the lung. And then once in a while for chest wall lesions, right on the inside, it can be good, particularly if they've already had a lot of surgeries, it's isolated area. It can be a reasonable alternative, but it also depends on having the interventional radiologist that's familiar with it. For the liver, cryoablation can be something quite good compared to surgery. Again, it has to be in the right location, like on the edge of the liver to do that.
Great, thank you. And what about options like TACE MWA as well?
TACE, that's embolization with chemo. This leads to the whole question of can you block off the blood supply of a tumor? Either bland embolization, it's kind of like plugging up a radiator with beads, so there's no hole there, or using chemo beads. We tend to do that usually just for liver tumors. And there's sometimes something even better. It's little glass spheres that have radioactivity on it. We call that radioembolization. So they do a test dose, and then they figure out through the physics how much they can give, and then about a week later give a bigger dose. But they need to know the blood supply of the tumor in the liver to do that. Other ways of using radiation is a whole nother topic, but we'll see if anybody's interested in that.
Going off of that, what if surgery is not an option?
Then you would use radiation. Now, most people think of radiation almost like comic books or what they read about atomic bombs, but the reality is radiation is very precise energy delivered in a very exact area, so they know where the radiation is and is not. It's like a beam, a flashlight beam. You only have radiation while the beam's on. So it's a way of providing high energy to a volume that contains the tumor. In the old days, we didn't think radiation worked well for osteosarcoma because we had relatively modest energy radiation machines that weren't as precise. This was in the 70s. You could radiate a tumor and within a year it would recur. Since then, beginning in the late 90s, there's information if you used a radiosensitizer. So a drug like a chemotherapy drug with radiation worked a lot better. So then from about 2010 on, they've come up with very precise ways of giving large fractions of radiation. Instead of getting your radiation over 5 weeks, it might be over 1 week, giving big doses very precisely. That's called stereotactic body radiotherapy. And that's become the standard of care for many cancers if you have a bone met in the spine. So spine surgery is really hard to do. It's hard to get not only a complete resection, but if you have a positive margins, you're going to need radiation anyway. So there's some locations where radiation might actually be the preferred means of local control for osteosarcoma.
Great. I know you touched on this a little bit earlier, but how do you sequence or prioritize chemo versus surgery?
They kind of go hand in hand. Then there's the who's on first. Your question. I'm sure people on the call are familiar with the Abbott and Costello who's on first. If you haven't, you need to check it out on YouTube. And you'll have problems with, let's say you have a leg tumor, lung metastases, and chemo. And, the orthopedic surgeon will say, I can't do this. There's lung metastases. And the lung surgeon will say, I can't do this. We'll be back to where we started. The leg tumor's making metastases. So in terms of prioritizing, usually what you try to do is look to see where the bulk of the tumor is. That should be controlled first. So the biggest tumor. Also location. I use the term troublemakers because it makes sense. everybody's been in a classroom with a troublemaker, right? So if you have a bad location of a metastasis, it's a troublemaker. And you should take care of that sooner than later because it eventually cause problems. And you want to handle it in a routine, thoughtful way instead of wait for an emergency like a spinal cord compression or you're coughing because of a hilar metastasis.
Gotcha. Thank you. And just quickly jumping back to glucose and glutamine, it's a good question from the audience. I have heard that there are supposedly the two main fuels for osteosarcoma are glucose and glutamine, in parentheses, not sure if that's true. Since you're recommending Helios, I'm assuming you're not concerned by this, and why?
Oh, that's a great question. Or glucose either. When we work in the laboratory, we'll use media to try to get tumor cells to grow because they won't grow in water. So they need a nitrogen source and also an energy source. So all cells do. But the way our bodies kind of keep control of metabolism is you can't have a blood glucose of 0. You get below 40 or 50, you'll have seizures. So you always will have some glucose in all parts of your body. You can control not having too high glucose by just having a normal diet. But you can't get away from glucose completely. So you just have to use some common sense on that. Glutamine's quite similar. Glutamine's our nitrogen shuttle in our bodies. And if you look at the concentrations of amino acids in your blood, all of us will say, drew a tube of blood right now. All of us, glutamine would be the highest amino acid in your blood. If your diet lacks protein, your muscles will break down and provide glutamine to the rest of the body. And the liver is kind of the traffic cop. Make sure that the rest of the body, including your intestines and your white cells, get some glutamine. So the amount of glutamine in the supplement I was talking about is just the same amount as in a high protein diet. So it's a food, it's not a super huge amount. What's kind of special is you're trying to provide it just to the mucosal lining, to the mouth, esophagus, stomach. So you're not going to have a bump in your blood glutamine. So it's safe to do the Helios. By the same token, it's also safe to eat potatoes and things that are be broken down in glucose. You just don't want a high glucose peak. So most people with a reasonable diet will do just fine. But this also brings up, are there ways you can harm cancer cells more easily than normal cells? And there's some evidence, mostly in the breast cancer literature, on intermittent fasting, which is something teenagers tend to do anyway. It means not eating breakfast, having a good lunch, having a real good dinner, and then not eating anything after dinner. So you have a 12 to 15 hour period where you're not taking in a lot of food. And cancer cells are less resilient to the effects of chemotherapy if you have intermittent fasting. Or they've shown this both in cell culture in animals and in people with cancers too. It might be one of the reasons that what you want to do is establish a routine where you feel good enough but not starved, and have some control of your diet but are not so focused on diet you don't enjoy life, because that's, everybody likes to eat and you don't want it to be a battle over what you eat and don't eat. Your body's going to always make some glucose and some glutamine.
Concerning genomic sequencing, how useful do you think osteosarcoma tumor DNA testing is?
It's useful, and it's going to become more and more useful for several reasons. The first is germline testing. Some people have the misfortune of having a p53 mutation, which is related to their osteosarcoma. So just having the diagnosis of osteosarcoma, you should get the tumor tested. And many times the tumor will have p53, but then that opens up the question, well, is this in the other cells or not? So that's a very common reason to want genomic testing of osteosarcomas. That said, sometimes you'll find things that are hints about what drives the tumor, but I think the testing's getting better and better. They'll not only just give you a laundry list of the mutations in the genes, but they'll give you more information on the exact type of mutations. There can be a single base change, which is called a point mutation, or the ones I'm most interested in the future are fusion genes and frameshift mutations. This is where an extra piece of DNA is put in the gene, so everything else is encoded differently. This might be immunogenic, and it might be something you can make a personalized vaccine to in the future. So the frameshift mutations, I love to see them on reports because it makes me start thinking, wow, we have some useful information. I hope a company like BioNTech can do something about this someday. Same with the gene fusions, where you have two genes that split apart and come together. That will be a unique cancer gene. And could you make a nested set of mRNAs or polypeptides for a vaccine? And then last but not least are tumor drivers like MYC, which is often amplified. I wish we knew more about how to handle MYC, but I think there's a company that's coming out with a MYC-specific drug. I won't name their name because they're in an early stage, but the cell data I've seen looks very promising. So without such knowledge, you wouldn't know. Hopefully, the information on the genomic reports you won't have to put into action. You'll respond to standard therapy, surgery, chemotherapy. You'll never need it. But if you need it, then you have that information there.
This one's from the audience. So do you have any concerns with melatonin in the blood affecting the quality of lung CT images?
Usually the amount of melatonin people take is pretty small. You're talking about 5 milligrams, things like that. I haven't seen any difference in the patients I've seen. I've seen a lot of chest CTs. What you're really looking at in the chest CT is trying to decide what's a vessel and what's a tiny tumor nodule. So I don't think the melatonin will affect that at all.
And then going off that.
They may mean, coming to think of it, they may mean metformin. And metformin won't affect a CT, but it might affect a PET CT because it affects the blood glucose and how cells metabolize glucose. So on that score, if you're on metformin, ask your doctor, see what the current, we call it standard operating procedure is in your institution.
And then going off that, what's the difference between a CT, MRI, a PET scan, and an X-ray?
Oh, first of all, cost. The X-ray is cheap. We're talking $50. The next is CT, and the most expensive are MRIs and PET CTs because they require more specialized machines. They take longer. The PET CT is a trace radioisotope that's fused with a PET scan to CT scan. The second is they all provide different information. The plain X-ray is really good for looking at bone mineralization. So do you have a fracture? Is it like a tumor that's ossifying and healing? You can see that on a plain X-ray fine. CT scans are good for bone, some soft tissue, but they're great for lungs. So it's far and away the best scan for lungs. MRI is good for soft tissue. So it helps surgeons know the extent of tumor, not only in the bone, but next to the bone and the nerves that are near the tumor. But MRIs are lousy for lungs because you're always breathing, you have motion. So you can't interpret lung MRIs very easily. The PET CT I find very useful for three reasons. The first is it'll find bone metastases in one scan of your whole body. The second is you can look at how much glucose uptake is in a tumor, whether it's a primary tumor or metastases, and you can tell the patients it's getting better or worse based on that standard uptake value, the amount of glucose going up or going down. And then last but not least, on the PET CT, it will help you. This is kind of the reverse. It'll help you know you have no new disease. So sometimes success in osteosarcoma is stability, that you have no new bone metastases. Your lung metastases are the same. And it's reassuring to know that the regimen's working.
And then what is the recommended scan schedule for during treatment for 1 year out, 2 years out, et cetera?
That depends on your risk. I wish it could be one size fits all, but it doesn't. What you look at is, did they start out with metastases, for example? Then you probably will need more chest CTs than somebody who never had. Did they ever have bone metastases? You may be doing some extra scans like bone scans or PET CTs occasionally. Usually what we'll do during therapy is watch the primary tumor get better to decide when to do surgery. Sometimes, it's pretty standard to do at week 12, but sometimes it'll be a difficult surgery and you have more than one area involved. You don't want a wound complication. So while you're waiting for that to get better, everything else is getting worse. So when to do the scans very much depends on extent of disease and diagnosis during primary therapy. Once you're done with therapy, a general schedule and is every 3 months for a year, every 4 months for a year, every 6 months for a year, and then yearly times 2. But that's just a general rule of thumb.
Hey, Dr. Pete, I had a couple questions come in about clinical trials. And specifically how to access trials that are outside the US for those of us that are in the US. And then we also had some people who are living outside the US who are wondering how they might be able to access trials in the US. So kind of both ways. And
That's a
then
great question.
to tag on to that, how to access a clinical trial treatment if you aren't technically eligible. So let's say it's for 18 and under, but you're 20, for example. So are there any ways to be able to access that particular treatment without officially being on the trial?
It's a very individual process. Fortunately, our government has this wonderful website, clinicaltrials.gov, that has an NCT number. So they'll describe the trial. Sometimes they'll give pretty detailed information on what you need to get on the trial. We call them eligibility and exclusion criteria, and a contact person. I think the key is you want to be very organized how you approach the people running the clinical trial so they know you're a good candidate. Either they can learn if the drug works and that you're healthy enough to either travel or to do everything that's expected of you on the clinical trial. Sometimes this means getting a summary, either from a second opinion or your doctor, so that you present as a known quantity. One of the good things about COVID is virtual visits. It's probably one of the favorite things I do. And that allows you to talk to the doctors at another center and actually ask the questions face to face, if you will, virtually. So you don't get on a plane and then find out, there's no way you could get on the trial. I also see getting on clinical trials as you're trying to develop a therapeutic alliance. The principal investigator on the trial has to follow all the rules, but you want to make it easy for them to follow all the rules. So if they know, what's involved, you have a doctor and a team who can keep you healthy in that medical center or outside of that medical center near home, that's helpful. But the long and short of it is each trial is different. Sometimes you have to have measurable disease to see if the drug's working. Other times you have to do surgery and then you get it as adjuvant therapy after the surgery. So the thing to do is investigate the possibility of the clinical trial before you get surgery so you know all the options. Right now, for example, there's one trial in Children's Oncology Group that you get the surgery, but you have 8 weeks to get on. So you want to line up all your ducks before your surgery, so it's not some rush. There's other trials where you get the drug and see if the tumor shrinks, but you should have a backup plan, whether it's surgery or radiation, if you get a disappointing result from the trial. So my advice for people about clinical trials is they're a great idea, but you have to have a backup plan and you have to be well organized while you're on the trial to stay healthy. And they always want to do what's best for you, not the trial. So if you can help them to do that, then it's win-win for everybody. The last part of the question, gosh, these are detailed questions, is what if you don't qualify for a trial? Let's say you're the wrong age, or you have a ANC of 999 and 1,000 allows you on the trial. Sometimes it's as simple as repeating tests. Other times, the principal investigator, the person in charge of the trial, can look at it and say, we'll make an exception. We can do what's called a PI override, principal investigator override. We'll make a deliberate deviation or violation of the clinical trial. But the way to do that is you have to inform the sponsor, you have to inform your IRB, and you have to document that. If there's no flexibility to change the rules, if you will, sometimes companies still want their drug tested, and then you can do what we call a single patient IND, where you get access to the drug, but you're not actually on the trial. You're just treated according to the trial as if you were on. This requires a very highly motivated, not only patient, but doctor too. The FDA has actually made this process pretty friendly, and it's one we go through with mifemuritide frequently for osteosarcoma. You get a letter from the company that makes the drug saying they'll provide the drug. The FDA can access the drug master file, so the FDA knows that it's the correct drug made correctly. And then the doctor administering the drug has to provide the FDA with their CV, their qualifications, and a short form of 3926. That goes to a special, extra friendly part of the FDA called FDA Onc Project Facilitate. They'll turn it around within a week and give you the number saying, this sounds reasonable, go ahead. Then you go back to your institution, to your Human Subject Committee or IRB. They'll say, this is reasonable. You have to consent the patient to the consent form that's understandable. Once you've done that, then you circle back to the company and they can ship the drug. Once you've done this a few times, it's not so complicated. But I've walked many physicians through this process, and it's, for some drugs it's possible, some drugs the company just doesn't want to do that. So that's how to get access if you're not qualified on a clinical trial according to the eligibility and exclusion criteria.
Moving in a different trajectory, how do you best manage radiation side effects?
Oh, that's a good question. For fatigue, you try to maintain your diet, but also hemoglobin. We know radiation works more effectively if you've got plenty of tissue oxygen. So you may need extra transfusions to get your hemoglobin 10 or above. For skin toxicity, what you're trying to do is avoid sunlight or anything that would add injury to insult. And then for mucosal surfaces, it's a good diet. Sometimes if it's the mouth or the esophagus in the field, we'll use Helios. And then last but not least is I always ask the radiation oncologist for the treatment plan. It looks like a contour map, so it's in color. So you know where the radiation is and is not. And that way you can anticipate what kind of toxicities you'll run into. Is it going to be bowel toxicity? If it's radiation of the hip, is the rectum involved or the bladder, things like that. So you can anticipate what you should look for by knowing the treatment plan. And then you sit down with the patient and say, this is what we'll expect when. The other thing I try to do during radiation is make radiation more effective. And commonly we'll use ifosfamide during radiation, but it's way less toxic to give it over as a slow infusion over 2 weeks than large doses over 5 days. So some of it means just kind of making it boring instead of, getting all your chemo at once and then waiting for you to recover and having low platelets and white cells for a while.
Following up on that, what would you say is the difference between EBRT, SBRT, and CyberKnife, and what works best specifically for osteosarcoma?
Each provides energy in a different, precise way. So I think of standard radiation as a smaller fraction over 5 to 6 weeks. SBRT is a large fraction, very precisely over a week, or once in a while we'll do it Monday, Wednesday, Friday, Monday, Wednesday. Stereotactic radiosurgery, SRS, we'll use that for areas like the spine or the brain sometimes, where it's a single or 2 doses of radiation very precisely. There's also another kind of radiation where you have radioactive drugs, and radium's a good example of that. It's injected like a bone scan, but any place that's making bone, like a bone forming osteosarcoma metastasis, the alpha emitting radiation will be deposited and then it's given over a slow period of time while the radiopharmaceutical decays. So with radium, its half-life is 11 days. So if you do the math, day 11, you've got half of it, day 22, a quarter. By a month, you're a lot less. So each radiation's got different energy and physical characteristics of how best to deliver. And each center will have a feel for what's possible for that particular patient. I like Erin Murphy, our radiation oncologist, because she provides very thoughtful consults. If she thinks protons are needed, she'll figure out a proton center near you. If she thinks SBRT is needed, we're really good at that. If she thinks standard radiation's fine, could be done just about anywhere, she'll let them know that. So it also depends on the experience of the radiation oncologist, and some have a lot more experience with sarcomas than others.
Okay, we have time for one last question of the many, many questions we got. And I'll come back to the many questions that we got that we didn't get to in just a second, but Andrew, go ahead.
Are there any promising immunotherapy options for osteosarcoma like CAR T or SNK?
Yeah, they're all promising. The question is, will they work? Now, the CAR Ts, it depends on the target. I like the B7H3, also anti CD276, because that's on a lot of pediatric cancers, including osteosarcoma. Whether you get the cells to persist long enough to work will be the question the clinical trials will have to solve. I know that's being currently done in Seattle. Steve Gottschalk at St. Jude's is doing that. So that's my current favorite CAR T, although there's other varieties and other targets for osteosarcoma. And then there's a variety of immune drugs. There's no way to tell which one's going to work best, but I like the OST 31164 for a couple of reasons. This is the COG AOST 2121 trial. And one reason for that is a lot of dogs get osteosarcoma, more dogs than people. So if they've tested a drug and it works in dogs, which John Connor, when he worked in my lab, we had a nice saying, 1 dog is worth 1,000 mice. So that drug looked quite promising and active in dogs with osteosarcoma. So I think that's a trial that we'd love to see get done quickly so we know if it's going to work or not. And it's got a convenient schedule. It's every 3 weeks after you resect all disease. So those are the two kind of promising to answer your question in an abbreviated way. There will be others, lots of them. The other one, if you have persistent disease, is anti-CD47 plus anti-GD2. CD47 is the macrophage don't eat me signal. So if you can mask that and you have an antibody on tumor cells like GD2, it tells the macrophages to gobble them up. That strategy has worked for lymphoma with 2 antibodies. Would it work for osteosarcoma? Probably Masner's lab thinks probably yes. Will it actually work in people? You just have to do the trial. So that's currently accruing in a few centers.
Okay, that's all the time we have for the question. My gosh.
It's been a delight.
So many questions. We also have so many more answers coming up next month when Dr. Matteo Trucco, who is Dr. Pete Anderson's colleague at Cleveland Clinic, and they work very closely together on lots of things. He'll be on Osteobites next month. We're going to have another Q&A just like this one. And whatever we didn't answer today, we'll move over to Dr. Trucco's plate. And we'll also take more questions. We just had so many, so I apologize if we didn't get to yours. I also wanted to mention that we do have an Osteobites with Cleveland Clinic's radiation oncologist. If you look that one up, it's such a good Osteobites. I love that. I love that one. And then also be sure and check out our website for the osteosarcoma clinical trials. You can find an osteosarcoma specific clinical trial in under 60 seconds. It's connected with the clinical trials website, the National Clinical Trials website. So all the information is updated and accurate and really, really an exceptional tool if you're looking for the next step to suggest maybe to your doctor. And by the way, lots of doctors use that tool because it's so quick and easy. So let's see, what else do I have to say? Mostly thank you to Dr. Pete. Most of all, I mean, of course for today, but most of all for your commitment to osteosarcoma patients everywhere. Your kind and expert care is so appreciated. I start crying every time I start talking to Dr. Pete about his lovely care of us. More information on this and all Osteobites can be found on YouTube, on our YouTube channel, on mibagents.org, or anywhere you get your podcast. If you registered for this session, we're going to send you links after this session, shortly thereafter. And by the way, next week, we're talking with Dr. Nicola Mason of University of Pennsylvania, who is a doctor of veterinary medicine who specializes in osteosarcoma and cancer in large dogs. She's going to be talking with us along with Dr. Damon Reed of Moffitt Cancer Center about the new human clinical trial, which succeeded in dogs first and canine patients for osteosarcoma called OST-HER2. That's next week, so same time, same place. Until then, thank you again to brilliant Dr. Pete Anderson and our panelists, Kara, Mia, Andrew, and Christina. Thanks, everybody. Be safe out there today in the snow.
Thank you, Anne.
Thank
Much
you.
appreciated. Yeah, bye-bye.
Bye.